So thank you, Mr. Chairman. Dr. Sigunin asked me to stand in, fill in for another speaker and give you a brief summary of the state-of-the-art of lipofilling in breasts. There are four key questions to be answered. One is, does fat grafting lead to increased difficulty in breast imaging and cancer detection? There are many articles that have been finalized the answer to that in the last 5 to 10 years, which show that lipofilling doesn't give you more macro calcifications or any other difficulties than a regular breast reduction or a mastopexy. The other question is, does fat grafting with or without cell enrichment of stem and regenerative cell increase the risk of tumor recurrence, which is again a very good question, because the mechanism by which fat grafting takes, which is angiogenesis, is the same mechanism for tumor growth. There have been many papers about that. The two most recent papers, one by Jean-Yves Petit from Milan, and the other one to follow by Mario Regens from Milano as well, showed that even though there was a slight suspicion that in patients with DCIS, low progressing cancer, there was a higher incidence of recurrence, the paper by Mario Regens, which followed that, showed that there is no increased risk in any patient group. Does cell enrichment improve outcome of fat grafting? Is it worth to spend the time and money to remove the stem and regenerative cells from the fat and then enrich it in order for it to have a better survival? The answer to that in normal tissues, in non-hostile tissue, which has not been scarred, which has not been irradiated, there's probably no difference between regular fat and cell-enriched fat. However, in irradiated tissues, where the ability to put fat is very small because the tissue is so contracted and atrophied, there might be a place to do that. And finally is, how do you evaluate the survivability and the staying of the fat long term? And we found that 3D photography has a practical use in that, and I will show you. One of the most exciting questions about fat transfer is, would it help if you use a vehicle to go along with the fat to make it stay longer or take better? And there are several clinical trials and laboratory basic science trials going to that. One is this one picture of ours of a recent study where we combine collagen made of acellular dermal matrices that is powdered and then mixed with fat to see if that would improve the survivability. And the other is by Ali Mujalal from Lyon, who has mixed fat with hyaluronic acid and showed here that when you mix fat with hyaluronic acid, you get a higher survivability when you do fat alone or fat with stem cells. This is his basic science study that was done 5 years ago, and this is a mice that has a collagen scaffold and just a negative scaffold and fat alone, and it showed that there is a higher survivability of the fat with the scaffold. When we put fat in, do we know which cells we are grafting? Of course we do, because this has been analyzed. The adipose-derived stem cells, while high in number in fat, are only 5%, 2 to 5% of the entire cells and regenerative cells within the fat. What we are grafting is basically the whole concerts of stem and regenerative cells, which together seem to work better than if you just use the stem cells with the fat. 33 years ago, I've done this patient, which was the first patient that I've done with a hybrid breast. A hybrid breast is the breast that's made out of her own tissues and an implant. And she had an extended radical mastectomy, so I used the latissimus dorsi to fill in the infraclavicular hollow and to give me a base on her tight ribs, a tram flip in order to give me the outside envelope coverage and an implant. The fat has been added to a matrix in the last 5-6 years to see if together they have any advantage over using just fat or just matrix. The matrix helps as a stabilizer. The fat helps as tissue augmentation for padding and softness. Together, both they dramatically reduce capsule contracture, and the question is, do you need them both? ADM minimizes capsule contracture, which used to be 25 to 30% of all implant-based breast reconstruction, by offloading the pressure of the implant from the lower pole envelope, by reducing fibroblast stimulation and inducing a milieu that is less inflammatory. If we take biopsies from areas of ADM and non-ADM, like to your left, when we exchanging a tissue expander into a definitive implant, we see that in the area of the non-ADM to your right, there's more cellularity, more proliferation, and more vascularity than on your left, which means probably more inflammation and therefore more capsule contracture. How does fat minimize its capsule contracture? Probably by downregulating inflammation and by upregulating angiogenesis. This is not very clear, because how can you downregulate inflammation but upregulate angiogenesis? It's probably more a process where the angiogenesis is upregulated, and once everything is stable, it downregulates, but we don't know for sure. Lipofilling techniques are not standardized, not the harvesting, not the processing, and not the placement. Fat is being harvested with vacuum, with syringe, with vibrating cannula, water jets, and everything. Those, however, has been validated, which means that the number of cells that are viable range between 60 to 80% depending on what technique you use to harvest the cell. So none of this technique really destroys the adipocytes as we used to think in the past. Validated means that the number of live adipocyte and stem and regenerative cell is graftable, so that most of your graft is something that is alive. Now, when you look at a late outcome of survived adipocytes, you ask yourself, where are they from? How did they get there besides you putting them? So the simple explanation is you put an adipocyte, it takes and it stays there. It can survive by dematurate, which means it loses all its cholesterol and it collapses, and then it rematurates. Or it is replaced de novo, either by the progenitor stem cells or by the host. So either by the graft or by the host. When you look at the origins of those, it depends at what window in time you look. This is the same adipocytes followed for 2 weeks. So it goes this way, basically. However, if you give it enough time, it goes back this way. So it depends when you look at it. So if someone said, I've looked at a fat graft and all the fat cells are dead, he probably looked at it at the beginning or at the end of those 2 weeks. If you wait another week, they're starting to go back. So it's very difficult to say how many of the cells die and don't regenerate and how many of the cells regenerate. But if you look at volumetric assessments, when the fat grafting is being done properly, then around 70% of the fat that you put in the patient stays there. The technique of fat grafting, we lost a video there. Let me see if I can do that. Yeah. Okay. So when you need the big amounts of fat, like here I'm using a micro air vibrating cannula, which vibrates 3,000 times in a second. And what happens here is that I could do 1 cc in every pass. So I do it through 50 cc syringes, which very slowly are advanced by my assistant. And like that, within a short time, in a breast like that, I can put 200 to 300 cc's. This is only one of the ways to do that. So here's a patient, let me go back here. Here's a patient that came to me for breast augmentation, and then she said, can you also do liposuction? And I said, yes. And she said, can you put the fat up there? So I said, let's try it. So we put her in the Brava for 3 weeks, and then we did a breast augmentation using the technique I just showed you, which took a little less under 2 hours. And here she is before, and here she is after. The degree of augmentation using fat in aesthetic patients is very moderate. Most patients look for more than that. And the Brava has a compliance problem because to wear it from 6 to 8 hours every day is not an easy issue. So you have to select your patients comfortably. When do you use it? In a tight breast that wants to be augmented with fat. If the breast is not tight but is loose, you don't need the Brava, you can get good results. Or in patients like this. This is my patient that 10 years ago had an augmentation. This is 8 years later after she had 2 children. The implant was 360 cc round, too big. It was over the muscle, which was too superficial. And after 2 lactations in pregnancy, her breast atrophied, and she got that. This is the same patient after we have replaced the implant to a smaller implant and put some fat in. This is another patient operated by someone else, 2 large implants under the muscle, lack of support, the nipple is going up and the upper pole has disappeared. I used a matrix to hold her breast in inframammary fold. I did the neo-subpectoral pocket to give the new implant a better chance, and then grafted her cleavage area to get this kind of result before and after. Or in patients like these that come to me with a chest wall deformity with a marked asymmetry in one operation of combined augmentation and fat grafting, we can get that result even when we augment the other side and get a reasonable result. 3D photography can really evaluate the survivability of the fat, how much of the volumes that you have grafted stays. So here's another patient with a chest wall deformity to your left, and here she is after 2 sessions of fat grafting. By putting a 3-dimensional picture one on top of the other, you can deduct the delta between what she has before and what she has now. You could also measure it. After you take this template out, and you know that this template is worth 205 cc's, well, we know that we have grafted in her in 2 sessions 200 cc's each time. So 50% of our fat has been retained. And you can see the difference after 2 sessions of fat grafting, and you can quantitate that. Patient like this is the same patient. She had a Brava in order to get enough tissues, and this is the difference between where we started to where we got in the beginning. For breast augmentation, you can easily evaluate these patients because immediately post-operatively and for 3 weeks, they look much more swollen than they are. Then the water is being absorbed, the swelling is going to go down, the ecchymosis is being absorbed, and so on. And then the patient wants to know where she started. By doing 3D photography, you can assess exactly how much of this fat has been retained from the word go, and it's only 1 photograph to do. In irradiated patient, fat plays a major role in simply modifying the scarring of the tissue. So, this is a patient after lumpectomy and radiation. In this patient, I've done one session of fat grafting and transposition of the nipple as a free graft to the center of the breast, and we got from here to here, and from here to here in one session. This is a male after mastectomy, and this is the same male after, I think, 120 cc's of fat inserted and transplanted into his left breast before he got the nipple reconstruction. This patient I showed you yesterday is a young woman who had an lumpectomy and radiation on the right side, and 3 years later got recurrence. She came back, she had a skin-sparing mastectomy with a 2-stage reconstruction with a matrix and a tissue expander on the right and an augmentation on the left. Then when she came back to exchange her tissue expander on the right to a definitive implant, she found out she was a BRCA carrier. So she asked to have a 1-stage reconstruction, nipple sparing, on the left side, which is exactly what we did. However, obviously because of the radiation, she had some depressions and irregularity on the tissue expander side. So we did several things. One of them was fat grafting, and fat grafting helped us to get from here to here. So you have 2 different products. One side non-irradiated, the other side irradiated, 2-stage with fat grafting to give you a reasonable aesthetic and symmetric result. Or this patient. This patient had a mastectomy and irradiation. With this irradiation damage, did not want to have a free flap or a free autologous tissue transfer. And in 2 sessions of preliminary fat grafting, we increased the soft tissue envelope on her left side, and then with a tissue expander and definitive implant, got that result. And finally, I'd like to share with you this patient that came to me with severe atrophy and radiation. She had 2 sessions of fat grafting to soften and resist some of the radiation damage on her tissues, and then a tissue expander and definitive implant, ignoring the position of the nipple, which was then excised and transferred to the right position. So, future of lipofilling of the breast, that it contributes to softness. Together with ADM or matrix, it contributes to stability. Both reduce capsule contracture, both improve contour irregularity, both are very helpful in irradiated patients, and they both work better together, but also alone. Thank you very much.